Welcome to Healthcare du Jour, where we dish up and digest the latest in healthcare. For the next 30 minutes, sit back as we bring you insight, commentary, and discussion on trending topics to the table, all expertly served up by our host and his guests. Now here's your host, Matt Fisher.
Welcome back, and thank you for joining as we dive into the hottest topics in healthcare. I'm your host, Matt Fisher. On the menu today is Nick Reber, CEO at Garner Health. Nick, welcome to the show.
Thanks for having me.
So, Nick, what I always like to do before getting into the main part of the conversation is to give my guests a chance to provide more of an introduction in terms of who they are and what they do. So, Nick, the floor is yours.
Sure. So, my background initially is really as a data and technology person. I ran new research development, research analytics at Bridgewater Associates, which is the large macro hedge fund founded by Ray Dalio. So, Ray was my boss for a number of years, for about 10 years. And there oversaw a lot of the sort of core algorithm development of predicting using big data systems to predict what was going to happen to the global economy. Somewhere along the lines, I actually had a bunch of health issues. I got misdiagnosed with back pain, had a surgery I didn't need, then actually had a complication on that surgery, needed multiple revisions, and got to really see the healthcare system from the inside out and just got fascinated with it, passionate about it, and found myself on nights and weekends reading more about healthcare policy than I was economic policy. And so that launched me in the healthcare world. I was pretty early on the leadership team at Garner Health, helped build the company, and oversaw growth, market development, analytics, and a few other things there. Really building a new version of a technology-driven health plan for individuals and small businesses. And then basically got frustrated with running a health plan and all of the things that you can't do if you have to play nice with providers and build networks and regulators and all this other stuff. And basically started Garner out of that frustration with the basic idea, a vision of actually being able to change the system of how healthcare really works. And to do so, I think you needed to be a player that was neither a hospital system or health system nor an insurance company, but rather be an independent third party. And so that's what we've been up to for the last 6 or so years here at Garner.
So kind of as you said, you wanted to change the healthcare system. So from your perspective, what does that actually mean? Because it's, I suspect a lot of people come into the healthcare world wanting to drive change, but from a lot of different perspectives. So I'd love to kind of know what that means to you.
Sure. So I think the obvious bad outcomes are pretty measurable, which is that we in the United States live about 3 years less than those people in Western Europe. And we also spend about 3 times more per dollar per person on healthcare. And again, most of that, if you look underneath the hood, is really due to our healthcare delivery system. And so those are the basic bad outcomes. The type of change that I think is necessary and the way that we sort of differentiate in how we see things is that a lot of folks think about the problems in healthcare as an incentive problem for providers of healthcare. That, people always talk, hey, people who deliver healthcare, the doctors get paid more the more surgeries they do. And so they get paid twice as much if there's an infection or a misdiagnosis than if they do it right? So bad incentives. The interesting thing is that those incentives exist in every market in the country. Like if you're making t-shirts on it and selling them on Amazon, wouldn't it be great to sell a $500 t-shirt that's incredibly low quality that people rip and need to buy another one the next day? Of course, the basic problem with doing that is there's a market incentive called consumer demand that won't allow you to run a business, won't allow you to sell very many t-shirts. And so that doesn't exist in healthcare because basically the way that doctors get more volume is by building a brand, basically building oligopolies, consolidation. And there's not the same accountability from consumers that you only get volume if you do the right things. And basically, that's what we're trying to bring about here at Garner is basically changing how people find healthcare, and in so doing, rewarding providers that are providing great, high quality care at an affordable cost with more volume.
So when you're talking about kind of finding care, can you help unpack that a little bit in terms of, what do you mean? Is that just finding a particular clinician, facility, or both?
Yep. So this has been a bit of a common misconception. I believe the unit of the healthcare product is the doctor or the provider in some way that, it could be a nurse practitioner or, a physician assistant, whatever it is. But basically, there's been a lot of work trying to turn healthcare into a marketplace for individual services. So you may have heard the transparency data that's been coming out, right? And the basic problem is that if somebody has knee pain and goes see an orthopedist, and the orthopedist says, walk down the hall for an MRI, nobody is going to pull up an app and shop and drive across town and burn a DVD and bring it back 2 weeks later and try to load it into the system, and it doesn't even work, right? They're just going to go downstairs. And so the unit of shopping, of searching, of finding, in our view, is the doctor. I just want to be able to say, hey, who should I go see for my knee pain? And then let that provider take care of me and make the decisions about what tests should I get, what my diagnosis is, what treatments I should get. And so at Garner, we really spend a lot of time. It's very hard to work on the data side, but to figure out where every doctor will send you, to which MRI center, to which surgery center, how accurately will they diagnose you, what tests will they do. And if you can do that, though, you can create actually really good consumer experience, because everybody wants help finding the right care. Nobody wants to be intervened with once they find a doctor that they love.
Yeah, no, and that's a great point. That kind of goes back to, kind of the selling point of the ACA originally, which is you're not going to have to change your doctor, or you're not going to have to change your plan. So it's, kind of building on that point that you made of people like establishing relationships with particular individuals. What have you found to be the most important data points to guide that decision-making process?
Yeah, I think it's fascinating because, the vast majority of folks today basically ask their friends, ask their neighbors, go on Yelp and Google, et cetera. And there's nearly none of that has any bearing on what is actually going to happen to you when you get into that room with the doctor. And so what we think, there's really three things that you would want to care about if you're a patient. The first is this doctor going to follow medical best practice, both in doing all the tests I need? So I got to get my screenings when I need them. I got to get all the tests I really need to accurately diagnose me, but also avoid the tests and avoid the surgeries that are shown to actually lower my life expectancy. So following clinical best practice, turns out there's massive variation in that. And getting doctors who actually use data and use the evidence to treat you is really important. That's one. Two is somewhat obvious. It's good outcomes. So you want to make sure that there's a low complication rate after your surgery. You want to make sure that after you get that surgery, you don't need a revision, and that it solves your issue over the long term. So number two is outcomes. And then number three, I would say some patients care about, and certainly employers who are facing a larger burden on this, is just purely the cost of the procedure or the cost of the visit. And what's fascinating is that there's no relationship between cost and quality in healthcare. So if you have the data, you can get really high quality, great adherence to medical best practice, and you can do so at a very low procedure cost. So, a knee surgery may cost $20,000 in one facility and $80,000 across the street. If the $20,000 surgery has better quality, let's just go there. So it's really those three categories.
Yeah, and kind of as you lay them out, they make a lot of intuitive sense. And then I suspect because we're talking about healthcare, how many problems did you run into in trying to gather the information to be able to then, kind of build out and provide, actionable and understandable insights on each of those areas?
Yeah, well, it is the Wild West out there on that. I mean, this is sort of why I started the company. Is I was at a health plan trying to understand. We had hundreds of thousands of dollars in of doctors in our network, and I was going to the data vendors and asking them for information on them, and it was just really never met my bar as a data person and a data scientist on that. And so there's really two big things. The first is the data set itself. So most of this data up until recently has been locked in the hands of a few payers. So the payers have it, and people have snippets. Maybe an employer has their own claims data, or a provider might have their data for certain patients. But it's really locked in a few national payers. And we've been one of the few folks that's really been sort of democratizing and bringing out a cross-payer data set. So we now have 3/4 of all the claims data in the country. We get that from almost everyone you can think about in terms of payers, healthcare providers, employers, coalitions that we work with, the government and CMS, and on and on. And we've really merged that together and created one coherent data set, which we think is a real step forward on the actual accessibility of the data. We typically have thousands of patients worth of data per doctor across the country. And then the way we analyze it is also very different. A lot of the work, if you look at how, if you get your insurance carrier and you really dig onto how they create those stars and hearts and badges on their website, it's really stuff that's been built in the 90s, the data science that was built in the 90s that's really not very sophisticated, candidly, and it doesn't actually predict health outcomes, cost outcomes, much of anything, really. And so we've really taken a much different approach and built, I'll happy to go into it, but we've built over 500 individual metrics that measure literally every aspect of a doctor's practice. So it's a bigger data set, and it's a very different methodology. And the combo of those we think is really important to taking a step forward to actually keeping people healthier.
Yeah, and kind of with that granularity of detail that you just described, I think you said about 5,000 metrics?
500. We're getting to 5,000. We'll be there soon.
Yeah. So with the innumerable metrics, which is, I think as you're implying, light years beyond where things have been for a long time, are you finding that, which ones are most important to maybe depend on the particular type of care that you're looking at, or, kind of how do you figure out which areas to highlight, or is that all kind of customizable by the end user?
Yeah. So number one, the biggest lesson that we've learned is there is massive and sort of shocking variation across the country in all specialties. And unfortunately, it also exists at big brand name hospitals too, all around the country. So there's massive variation in all types of care, whether that's primary care, things like cardiology, orthopedics, or more rare things like unique forms of cancer, et cetera, et cetera. And what's fascinating, though, is the nature of the variation is different by specialty. So, if you're cardiology, maybe there's massive variation in the usage of testing that is invasive and actually lowers people's life expectancy unless you really need it, or the overutilization of prescription drugs and putting people on 6 drugs that have all sorts of issues and side effects when they're combined. Whereas in orthopedics, it turns out a third of the knee replacements really don't follow evidence-based guidelines. So it's more about clinical decision-making or lowering a surgical complication rate. And primary care, it's more about, treating the patients yourself as a primary care doctor versus referring everything out. I don't have time for you. Just go see a specialist. There you go. So there's huge variations, but it's really by specialty. The type of the variation is very different.
And I think that's really interesting, but, I think also as you kind of probably started to unpack it, to some degree made sense. I think maybe as you start thinking about, what the typical interactions you're kind of describing is between a particular specialty and the patient. It's, kind of hearing you say, for example, primary care has a lot of, high touch interaction engagement between the clinician and the patient makes sense because that's the person who you're likely seeing for a longer period of time, as opposed to, maybe a more focused specialty where hopefully you're just in and out relatively quickly. But thinking about that, kind of how are you starting to see maybe patient engagement or patient expectations change? Because it sounds like a lot of the information that you're gathering is to help patients make a more informed decision and choice as they're going about seeking and engaging with care.
Yeah, so a few trends I think are emerging as we look at the data on this. Number one, people are using more digital tools than ever, and the role of the primary care doctor is diminishing. So those are, I think, 2 big themes. So that it's now about 3/4 of the people do some form of digital search for a doctor before they go see the doctor. And so, again, that could be Google and Yelp and all of these other things, look for the hospital website, et cetera. And then the other thing is that they're doing that and not just going wherever their primary care doctor says. So that number, it used to be the vast majority of referrals were made by primary care doctors. Now it's only about 35%, according to our data. And so that role is massively diminishing throughout the country. And then the other thing that's interesting that we think is really, that when we test it, is it's really only about 20% of people who really care to look at the data in depth. when we do a lot of user research, we can tell people, hey, here's a doctor who has X complication rate on the surgery you're about to get, and here's a doctor who has 3X that complication rate. And it's only about 20-25% of the people who really want to engage at the data at that level, which is understandable because this stuff is very complicated. And so here at Garner, what we do is we not only give the information as needed, but we also work to create financial incentives, which we think is the single biggest key if you're actually going to change behavior, is to have a clear financial platform where people who engage get richer benefits than if you don't engage. And so those are some of the things that we've seen in the trends.
Yeah, no, kind of, as I said, creating incentives makes sense because it's, if you're not having some spur behind it, it is tough to change behavior. And for those of you just joining, I'm talking with Nick Reber from Garner Health. We're talking a lot about clinician data and finding data, and then kind of picking up on that incentivization point that you just raised, Nick. Can you provide some examples of what that might look like, or maybe information around what you've seen to be less effective? And kind of one of the things that pops to mind is, I just remember, I think it was as the COVID vaccine was being rolled out, different states tried different activities, a lottery or other financial rewards that were trying to encourage people to obtain that vaccine. And the data afterwards seemed kind of spotty. So, given everything that you've already outlined so far, I suspect you probably have a pretty rich data insight into, some of the activities that you've tried out.
Yeah. So in terms of, I think what's important and sort of what works, it's important to think about, remember that 15% of the patients is 85% of the cost. And that these folks have serious, often life-threatening issues that are going on. And that if you have to create incentives that are aligned with that and clear. And so what has been tried historically when people say incentives is, I'll give you a $20 Amazon gift card or pay for your $20 copay. And if someone is suffering from a life-threatening disease and they think the best care is not where you're sending them, there's no way. Forget it. And so what we do, so it can't be small and tiny stuff. It has to work for people who are going to have serious issues. And you also have to keep in mind that most people who have care, meaningful care, are going to be through their deductible anyway. And so you have to find something that works for those circumstances. You can't say, well, it's, a lot of the times you get these calls from insurance companies, hey, you can get a cheaper surgery over here. And you're like, listen, I'm going to be through my deductible anyway. My employer's going to pay for that. I don't care, right? And so what we do is we work with all types of employers. Often they're a little more blue collar retailer, but we also have a lot of white collar groups. And basically we have, take a client that we work with in the Midwest. They had a $3,000 deductible for an individual, $6,000 for family. They were really struggling with rising healthcare costs and how do I help my employees with this? And we said, great. Well, why don't we make your family deductible instead of $6,000? Let's make it, I don't know, $7,000 or $8,000. And you think, well, my people can't afford this. And we say, great, but let's give your employees an option for free healthcare if they get with the program. So now your kid gets sick, you have an $8,000 deductible. Maybe you make $50,000 a year. You probably don't have $8,000 in your bank account. So you have two options. One is to surf the internet and ask your friends and go wherever. And the other option is to use the Garner tool, and your employer will pick up the tab for all your medical bills. And it turns out under those circumstances, there's enough savings left over for the employer because the member's healthy that they can you can offer, through Garner, just free healthcare. Hey, go wherever Garner says. You're going to get really high quality care that's in network, free. Or if you don't, that's okay, but you're then going to have to, come out of pocket and pay for it. And you're probably going to get lower quality care and have complications, et cetera. And that level of intense financial incentive really works under those circumstances. We find about 75% of the people, take our recommendation because the data says it's better health outcomes and it's free versus go bankrupt. And that's sort of the thing we think actually works. It's pretty, you don't have to go all the way. That's a pretty intense model, but towards that type of model is what we think really works if you really want to dramatically change things.
Yeah. And kind of, even if you don't go to the extreme end of that model, it sounds like if you're moving along that model to some degree, it also ties into what seems to be the evergreen hot topic of value-based care, because implicit in what you were just describing is you're encouraging patients to see and seek treatment from the clinicians that have proven better outcomes, which I think you also said pretty clearly as well, is that produces financial benefit, because if you have better outcomes and you can have more efficient care, it costs less and you're going to recognize savings.
Yeah, so and totally agree. You don't have to go all the way to that extreme model. You can sort of put a little bit of a toe in the water and ease your way in. The interesting thing on value-based care, I have a bit of a non-traditional view on that, having negotiated value-based contracts across the country while I was at Oscar. And my view is that I'm going to paint it with an overly broad brush here, and there's a bunch of nuances, but in a lot of ways, value-based care has proven to not really work. Not in all markets, in certain pockets, it's working well. But the basic reason why it's not working, at least in the employer market, is because I cut a big deal with a big brand name hospital system at one point. They did all the analysis. They had all sorts of shared risk and all these sorts of things. We were paying them per patient per year rather than per individual service. And they did a whole bunch of analysis. They said, hey, honestly, here's what we're not going to change any of our behaviors. We're going to do exactly the same stuff we've been doing. Because if we start avoiding surgeries and lowering complication rates, here's what's going to happen. In 3 years, we're going to renegotiate the contract and the whole pie has gotten smaller and we're going to get the same slice of a much smaller pie. And so we as a health system need the pie to be as big as we can. We need people to basically be sick and in the hospital. And if not, we don't really exist and we don't have the same profits and the ability to survive as we did before. And so what I think is going to work is much less value-based care and much more just changing volumes. It's kind of like a restaurant. Most restaurants, you don't pay like a monthly subscription fee, or you don't pay like for all of your health needs or all of your, like that. What you do is you say, hey, if the restaurant brings you a dish that's really bad, you just stop going to that restaurant. You lose customers. And I think that's what's going to work in healthcare, is just driving patients or customers to providers that are doing an awesome job and rewarding them. And it doesn't matter. You can pay them per patient, per procedure, per whatever. It doesn't matter. And then you basically take volume away from those that are not doing it right. And that's kind of how restaurants work. That's why restaurants are always getting better all the time. And I think the same thing will happen in healthcare if we can get this thing right.
It's an interesting perspective, because I feel like I've been having the conversation more frequently recently that, I think, as you just said, the approaches to value-based care that have been followed for the past, decade or so haven't measurably moved the needle, and nor have you seen, majority or kind of predominant uptake of those models. So I think, as you said, take lessons from what we've seen and then hopefully be able to kind of wean out what are the positives and then be able to enhance those. So it's, I kind of like your analogy really a lot, because you also hear the frequent analogy back to the cost issue of, you don't go to a restaurant, order your entire meal, and then pay for it 3 or 4 months later. You get the bill right then and there. So it's, it all kind of becomes interconnected of, if you can better understand what you're getting and how you're getting it, then you're going to, be able to change your behavior from an informed basis.
Yeah, exactly. I mean, the difference obviously between a restaurant and healthcare is that in a restaurant, you get the bill, but also you can taste the food and know whether what you're getting is good. And what's fascinating is people don't know, of the people who have, where the doctor is at fault for a major medical issue, they often have great reviews of their doctor if the doctor has good bedside manner. And so what those people and there's the whole, to your point about pricing and payment, there's a whole, everybody's insured. So they're not like paying the bill. It's like their company's paying for the bill, just like if you go for a corporate dinner, everybody orders the most expensive thing on the menu. So what you really need is someone to kind of ride shotgun with those people as they enter the restaurant and give them information on the quality of the dishes and the cost and the right incentives so that they can lower the cost. And that's sort of, we think, the model. And if you can do that right, then you'll help guide people to the right restaurants, and the great restaurants will grow and get more business. And the ones that are really not doing right by people will go out of business or have to evolve. And we think that's a healthier version of the country if we can get it right.
And kind of to get further into that model, who do you predict will be the primary driver of influencing that behavior? Because it sounds like, to some degree implicit in what you've been saying is that might be the employers, because they're continually facing a higher cost of providing access to insurance and coverage of insurance for employees. So, that might be the way to finally get another one of those evergreen topics of employers are going to be the ones who cause that shift in the system. So is that kind of an accurate assessment, or do you think there's going to be other players that come to the fore to help push in this direction?
Yeah, I think it'll be employers and primary care doctors, independent primary care doctors. The employers, I think, are at a real inflection point. I think they got a little bit of a respite through COVID of lower costs because nobody went to the doctor. And also there's some inflation dynamics that are actually lower healthcare inflation through that time. But now healthcare inflation is raging as fast as it ever has at a time where probably revenues and profitability are going to be weakening. If you look at it, certainly outside of the very, very largest tech companies. And so that's going to be a bit of a perfect storm for employers. And it's going to be really tough for them to survive in the old status quo, renewing my basic vanilla plan. And I think they're going to have to create a world like we've done in business travel of, no, you can't fly first class all around the country everywhere. Like, okay, and you can't stay in the 5-star hotel. We'll pay for the 4-star. And if you want to buy the 5-star, you go ahead, or whatever. And similar, it's actually different in healthcare because you can get high quality at a low cost, but we're going to start seeing a little bit more shifting responsibility, I think, onto the employees to make decisions. And, we think tools like ours that'll help. And then interestingly, although the other thing employers and everyone's doing is shifting more risk onto the primary care doctors who actually have better alignment and better incentives. And as those primary care doctors need to make higher quality, lower cost referrals, they will also drive more volume. And we at Garner actually have two products. We have an employer product, and then we also have what we call Data Pro, which helps primary care doctors do referrals. And what's fascinating, we're controlling well over 1 million people now. We're one of the larger differential drivers of volume in U.S. healthcare. And what's also interesting, we now have hospital systems call us and say, hey, how can we work together to get more volume? I'd love more volume. How can what can we do to get better? How can we improve? And those are really exciting conversations for us.
Yeah, and even that type of a question sounds like a pretty significant shift in thinking. And Nick, believe it or not, we're already almost out of time. So I'm going to close with one final question and ask for, as maybe a 5-word kind of pithy answer if possible. But what has you most optimistic about the future of healthcare?
I think the basic need for the payers of healthcare, the employers and government, to really shift incentives for all of their members, I think is going to be really exciting.
Yeah, so I think a lot to watch on that front. But as I said, believe it or not, we are already out of time. I want to thank my guest, Nick Reber, for a great conversation today.
Thank you, Matt. Appreciate it.
And thank you to everyone listening. Keep the dialogue going and connect with me at #HCDEJURE. I'm Matt Fisher. Until next time.